Duane, hi, can you hear us? We can hear you and see
Yeah, can
you.
you guys hear me?
Yes, perfect, perfect. So,
Great.
gives me great pleasure to introduce Duane Pinto. He's been in Boston for a long time. He's associate professor of medicine at Harvard Medical School, chief of the interventional cardiology section at Beth Israel Deaconess Hospital, extensive experience in interventional cardiology, and extensively published. And recently, I think, also took on a role as chief medical officer for JenaValve. So exciting role over there. Duane, we have a hall full of people eager to hear you talk about TAVR and your tips and tricks for it.
Thank you so much. I really appreciate the opportunity. And I also like to see some of my friends like you and John. So I'm glad John is staying on because, I get to show him some of my complications and we can learn from each other. I just wanted to introduce some concepts that the experienced operators already know is, in general, as we approach procedures, we want to avoid the avoidable, planning ahead and trying to, do our best to eliminate complications, knowing that they will never totally be eliminated. Then we have to prepare for the inevitable so we know how to react when a complication occurs. And then something that I think is the most difficult is to problem solve in the moment.
Could you share your screen, please?
It should be sharing. So let me just see if there's some way. Is that better?
No, we can see you really well, but we don't see your screen.
Okay, let me just see. I'm going to disconnect. Is that better?
No, we can hear you, but we don't see anything now.
Okay. All right. Better?
No, not yet.
Okay. Let's see. How's that?
Now we got it.
Yeah? All right. Thanks, John. Let me just go into slide mode here. Is that better, Osman?
Yes, got it. Yep, we can see it and we can hear you.
Okay. As mentioned, and then there's the kind of the third category of things where, you're faced with something that you've never seen before, and how do you solve the unexpected? So I'm going to spend a little time on each of these, but these are kind of the major complications. I think John mentioned some of these in his bicuspid talk, but this is what we're worried about as problems that can be reduced or mitigated before the case. And these are things that we can anticipate the risk of some of these happening. We can see that this person is different than the others when it comes to risk for coronary occlusion or a vascular complication. John showed a case of annular rupture. If you're looking at certain morphologies of valves and calcification, I think we can anticipate that this may be a concern for the patient. By sizing appropriately and perhaps picking a valve, we can reduce the risk of paravalvular leak. Vigilance when it comes to LV, RV perforation from either our wires or pacemakers. And then stroke is a tricky one. I think that reasonable people can disagree about whether we have adequate stroke prevention strategies, but we'll go into that in a second. So strategies to reduce the risk of occlusion. Valve type will certainly play a role. I have a biased view of this when it comes to the choice of a valve that perhaps may reduce the chance of coronary occlusion. How you deploy the valve, where in the annulus do you deploy the valve, whether it's low or high. That can, in some cases, help with reduction in the chances of coronary occlusion and perhaps coronary access later. Obviously, there are more advanced techniques like basilica or leaflet laceration, or prophylactic or preemptive snorkel stenting. Annular rupture and PVL, again, choice of valve, whether you use a self-expanding valve or a balloon expandable valve may affect this risk. But as John said, whether it is a balloon expandable or a self-expanding valve, it's the ballooning, whether it's pre-dilation, post-dilation, or deployment, that is often the cause of the annular rupture. Deployment strategy, whether you undersize or how you feel the deployment is going with the sapien valve, and then really is, again, anticipating with appropriate sizing. So what about risk of stroke? There is a healthy debate about whether uniform use or selective use or any use of cerebral protection reduces the risk of stroke, all stroke, important strokes, imaging strokes. All of these things are perhaps a subject for another time. Whether pre and post dilation make a difference, I think it's intuitive that more manipulation of the annulus leads to increased stroke. I would say some of the basic stuff that we can do is ensure proper anticoagulation, no accumulation of clot on the devices before we put them in, being meticulous about that. Avoiding over manipulation of the equipment. If you see that someone is having a hard time in the arch or crossing the valve or delivering things, perhaps a more experienced person can take over. And then obviously we still have to remain cardiologists and treat atrial fibrillation and be meticulous in managing the risk of bleeding versus the risk of stroke. Here's a very busy slide, but just looking at the risk factors for one of our disorders, coronary obstruction. So when you look at these things, when you see your patients before in your case planning, small sinus of Valsalva diameter, whether it's a female or a male, low coronary heights, I think the conglomeration of multiple factors, so small sinus of Valsalva, small STJs, low coronaries, all of these things should raise our eyebrows of whether this person is at risk for this complication. Here's a case of a patient with very low coronaries in a valve-in-valve procedure. You can see the sinuses are very small and the coronaries are very low. We anticipated that this was going to be a problem. And so as such, we prophylactically had a stent in place. And as you can see with the Evolute valve in place, the heart is hypocontractile. The person had arrested, but we were prepared for this. Deployed the stent, opened up the valve, opened up the coronary, and the patient recovered quite quickly and did fine. So reducing the chances of vascular complications, I think the ultrasound and micropuncture access are very important for me in reducing complications. And I think if you don't use this and get experience, you will see the advantages. I generally do a quick angio before insertion of a large sheath to make sure that there's not a complication at the groin. The days of iliac rupture and such, I think, are now gone. Our problems are at the common femoral and in the external iliac from dissections rather than iliac ruptures in these catastrophic events. So there should be strategies employed to help mitigate this.
2 minutes, Duane.
Okay. And so I think here, just vascular access, I think a concept that there's the functional part of the common femoral artery rather than the anatomic portion, and that we should be focusing upon access there so that we can treat things effectively. As I mentioned, I use micropuncture and ultrasound, which are just examples here. So preparing for the inevitable when these things happen, I think mitigation for one of these complications is the goal, and knowing the crossover technique, having the equipment on a cart, anticipating what your needs are to covered stenting. I can share this with everybody, but this is our strategy when there's a suspected bleed or you need to cross over. I'd pay attention to the vascular part contents. Those are the things that need to be brought in immediately when you say, I need to cross over and deal with this complication. These are the catheters used for crossover. All interventional cardiologists should have this in their toolbox of how to cross over the aortic bifurcation, put a wire down the common femoral, as in this case, and inflate a balloon so as to stop bleeding. One can also do this prophylactically and use this as a location wire to access the common femoral, and then you advance the sheath. This is an example of an axillary access where there was bleeding and that very same technique was used. A wire was across, a balloon inflated, and external pressure held. So in this axillary impella, or TAVR could be, balloon tamponade works, and this works in the common femoral artery. So I just want to close with the last slide here. This occurred 2 days ago. John knows I usually make my slides like 24 hours, 12 hours in advance. But in this case, this is something I'd never seen before. A sapien valve slipping off of the balloon and embolizing above. So, we were able to keep our wits about us and deployed the second valve, and then the first valve, which had been deployed in the aorta, we inflated a Palmaz shot stent to keep it open, and ultimately the patient did fine. So you need to keep your head when others about you are losing theirs and blaming on you in a complication. I add into if you can keep your head about you when all are losing theirs, perhaps you don't even know what's going on. So these complications always keep me humble, and I'm always learning from them. And I look forward to any questions or comments from the audience and panel to, again, help learn more. So thanks very much, and sorry to run over a bit.
Thank you very much, Duane. Thank you so much. And a round of applause for both Duane and John. That last slide is a reminder that no matter how many cases you have under your belt and you have extensive experience, sometimes things don't go as planned. Was that because the pusher catheter wasn't pulled back far enough, you think? Why did that valve embolize?
Yeah, it's still a little bit of a mystery. The pusher was pulled back. I will say the difference between a regular case and this is there was extreme difficulty advancing through the sheath. And then when we loaded the balloon onto the valve, I saw a little bit of contrast in the distal balloon. I don't know how it got there. I don't know if the inflator kind of was unwittingly had advanced some contrast into the balloon. But I think what happened is that balloon partially inflated, and then that was more compliant, and there was a differential expansion of the balloon. And so you saw the more proximal portion of the balloon was inflating later, and I think it just kind of watermelon seeded things back. I'd never seen it before. The clinical people there, who obviously see more cases than us, had not seen it before. Maybe others, Sahil, John, Ramesh, I see you're on. I don't know if you guys have seen or heard of something like this, but this was a first for me a couple of days ago.
Yeah, and I'd like to welcome Dr. Ramesh Dagubati, who's just joined us. Welcome, Dr. Dagubati. Did you have any comments? I don't know how much of the presentation you caught.
No. Yeah, thank you very much. I didn't know this is a very unusual complication. I was wondering, Duane, do you think we could pull back on the inflator? I know we don't do that normally.
I don't know. I feel like I don't want to add any more complications, any more like steps to the procedure. Already it's like a 3-person thing. Somebody's, looking at the wire, somebody's inflating, somebody's got their hands on the, to move forward and back with the catheter. So I think the act of removing the negative pressure, then starting to inflate and clicking the thing over, I just don't trust everybody. So I'd rather just keep it simple. And I'm also a little worried, Ramesh, that if you're sucking negative, maybe it's not as mounted on the balloon is tight and that you might have more chance of sliding. So, these aren't like stents, coronary stents, where they're, supposed to stay on there through a lot of push force. It didn't take that much force to load the balloon on the stent, so it doesn't take that much force to get it off,
Yeah. I'm going to open it up to our panelists and the audience if they have any questions for John or Duane. Ali?
Yeah, thank you so much for a very interesting talk. I wanted to ask John about a question regarding the bicuspid valve. That we do a lot of bicuspids in Pakistan, and we've got a high proportion of that. So the calcified RAFI with the calcification of the leaflets and that kind of valves, usually the depth-wise, they are held with the leaflets. So usually their depth is probably 0 or -1 even with the evolute. Do you guys have any experience about the depth of these? And the second is that we go with the estimated orifice area majority of the time. I downsize the valve if it's a bicuspid, and if it's on the borderline, it's a tricuspid, I upsize it. Do you guys do the same, or is there any difference?
Yeah, I think, so to answer the two questions, so similar to you, we've found that if you implant high, you often can get away with it. I will warn that I've had cases with heavily calcified where we've implanted high and we haven't sealed as we thought we would. And it's why I've sort of moved more towards not implanting at 0 or negative for bicuspids. Having had a couple of them, I really try to implant it at 1 or 2 millimeters so that I am sealing at the annulus, because I think you almost always will seal at the annulus, even if you don't necessarily seal at the level of the leaflets. Now, I think some of the colleagues around the world, there's this Hangzhou solution where they'll inflate a balloon and inject contrast to see where exactly they've sealed, if it's at the level of the annulus or at the level of the leaflet. So that may be a little bit of an elegant way to do it, although we have not fully adopted that approach. The calcification is tough in these cases, and when you have these severely calcified valves, I think you have to decide, where you think you're going to seal, where you're going to get paravalvular leak. I would agree with you at the border sizes with a bicuspid, I tend to downsize. For me, it really depends actually a little bit of which valve I'm using. I don't love to downsize balloon expandable valves these days. I'd rather put an extra cc in than take a cc or 2 out. And with self-expanding ones, I think it depends on the size difference. I feel a lot more comfortable going from a 26 to a 29 evolute. I'm a little more hesitant going from a 29 to a 34 evolute. Some of the data around the 34 evolute from around the world is a little bit concerning. And so it really, for me, it depends a little bit on which I'm choosing between, and also obviously the size of the sinus of Valsalva in those two situations.
I'd say that I'm not good enough to actually place the valve exactly where I want to within a millimeter or two. And so I look at what the failure mode is going to be. And for me, it's worse to be too high and have not sealed than to be a little lower and take the risk of pacemaker, because it's just terrifying to me when I see the valve pop up a little bit, or I'm way higher than I thought I was. And have I really sealed? Because now it's a second valve or something or the other. And that failure mode is much more stressful to me than to say, okay, I'm 1 or 2 millimeters lower than I wanted to, but I sealed, I got the patient a good result, but they're going to end up, perhaps with a bundle branch block or a pacemaker or something like that. Yeah. So to me, just like being very not confident with the current selection of valves of can I be within a millimeter or 2 of where I was during positioning makes me behave that way.
So we have a quick question from the audience about the importance of intercommissural distance in bicuspid valve sizing and TAVR planning. Is that something you guys factor in?
Meaning the size of the sinus, or
I think what they mean is if it's a type 0 bicuspid, then the shorter diameter, or like the intercommissural diameter.
Gotcha. So it becomes a little more oval when you take it up. I think that's one of the places, and it's surprising, but if you look at the bicuspid data, now again, these are selected patients, But in fact, the type zeros with the self-expanding valve had less paravalvular leak, less mild paravalvular leak than the type ones. So I think while we think that initially when you're using at least with a self-expanding system, that at the level of the annulus there, and even at the level of the leaflets is able to sort of take that shape while still maintaining the circular shape where the bioprosthetic leaflets are, it is not much of an issue at all. In fact, we were surprised with how nice the results were.
So usually intercommissural distance is very important, measuring about 4 millimeters above the annulus. If the intercommissural distance is smaller than the annular dimension, choose the intercommissural distance for sizing the valve. So that actually that's what probably I think the question was. Yes, it is very important to look at the intercommissural distance and not just the annular dimension as well, alone.
I hope Ramesh is somewhere in like India or Pakistan or London where they're driving on the other side of the road because you know, I think that hopefully he's not going to get in a car accident.
Yeah, I'm sorry, I'm in India for another valve meeting.
Oh, good. See, you're not driving. That's good. Okay.
Okay, I think perfect. Thanks, John, and thanks, Duane, for amazing talks. And I think